What happens when you discover decades later that the information you were given about menopause, or never given at all, was wrong? For millions of women now in their 50s, 60s, and 70s, the fallout from outdated science, cultural silence, and medical fear meant they went through menopause without support, without hormones, and without options. Today, Dr. Kelly Casperson is here to help us rewrite that story. We're talking about what modern medicine actually knows about HRT, why so many myths still linger, and how women of every age can step into midlife with clarity, agency, and confidence. Welcome to All About You. I'm Dr. Shauna Watts, GP and women's health advocate. Every week, I share evidence-based conversations that help you navigate the changes of midlife with clarity and confidence. Today, we're talking about something that hits home for so many women, especially those now in their late 50s, 60s, and 70s. An entire generation went through menopause without support. They were told HRT was dangerous, told their symptoms were just aging, or told nothing at all. But the science has changed, and so has the conversation. In her new book, The Menopause Moment, urologist and podcaster Dr. Kelly Casperson brings modern evidence, clear thinking, and a whole lot of myth-busting to this space. Together, we're unpacking why it's not too late to understand your hormones, why fear-based messaging still persists, and what every woman deserves to know about thriving in midlife and beyond. By the end of this episode, you'll understand why it's never too late to explore hormone therapy, even if you were told otherwise, what myths about HRT still hold women back, and what the evidence actually shows, and the real role of testosterone for women, from motivation and mood to vitality and sexual well-being. Remember, this is general information only, not personal medical advice. Always consult your own healthcare provider for guidance. Dr. Kelly Casperson, I am so delighted and excited to have you back on the podcast. Welcome back.
Thank you for having me back.
I am very excited to talk about your new book. Now, the reality is that you and your book and your podcast have been absolutely struck a chord with so many women all over the world. They've embraced you and love you. What are the conversations that are just keeping you going and giving you the energy to show up every single day, Kelly?
Oh man, well, first of all, it's like the suffering, right? Like the suffering's so big. And when people get distracted about stuff, like I was just, texting some friends today. I'm like, just focus on the suffering. How do we help the suffering? That's why we show up, because we're here to help suffering. And it just clarifies all of the noise in the world of we're here to help women suffering. That's my job. And why, so that's why I show up, and why I keep showing up is women tell me the stories, right? Because of you, my mom got on vaginal estrogen. Because of you, we saved my marriage. Because of you, I can sleep through the night. Because of you, I started a business, right? And it's over and over and over, which just speaks to how big the problem is. Right? I was talking to somebody this week. I was flying back from Orlando, and I was in the Alaska Lounge. That's our big flight here, the Alaska Lounge. And the woman at the Alaska Lounge counter, she's like, "Oh my God, Kelly Casperson," right? So she came and she talked to me, and I'm like, "Do you think people just look around and think everybody's fine?" Because I'm like, everybody's not fine. And once you know that, the level of compassion of why you're doing what you're doing, because you're like, oh, everybody thinks everybody's fine, but they're not. Right? And just speaking to empowering women, teaching them how to talk to their doctors, teaching them how to get a second opinion, teaching them that their symptoms are real, right? And just empowering them and being like, I got your back. I got your back. It can get better.
Yeah, I love this. And there's so many bits of the book that I want to delve into, but I want to jump straight in and talk about a group of women that I'm beginning to see in increasing numbers making appointments. And that's women who have been nicknamed the boomers. So they're kind of 60 to 79, and they missed out on hormones, and they are showing up with osteoporosis. They're showing up with really bad genitourinary symptoms. Many of them haven't been able to have sex for years, and they are mad, and they are so annoyed, and they want to know if they can take hormones. Or is it too late? And I'd love to know what your approach is to this group of women. And are you seeing an increasing number of this group of women presenting to you?
Yeah, so boomers are a huge group. I think millennials are technically bigger now, but boomers are bigger than Gen X. And the average age of boomers when the WHI hit, which again is a big study that caused a bunch of fear, that was in 2002. Average age of boomers was like 51. So they were just hitting menopause, right? So now fast forward 23, 24 years, now they're 74, right? And I have an old podcast episode called The Boomer Should Be Pissed. And I've done some episodes since then because I just started to listen to them and they're being very much dismissed, right? And there's a couple of reasons for that. Number one, people assume that they're fine because of the stigma that, like, well, hot flashes only last for 7 years, right? Aren't you over that? You're fine, right? And it's like these women aren't fine. They haven't slept in 20 years. They're frail. They've got osteoporosis, osteopenia. Their friends are breaking hips, right? Mental health issues. Haven't had a sex life. Wet in their pants, right? Horrible. They're on their second knee replacement, frozen shoulder, right? Like musculoskeletal stuff. And a lot of people don't realize that that's postmenopause symptoms of low hormones, meaning once your hormones go low, they stay low. And some things like genital urinary syndrome of menopause, that's progressive, meaning it gets worse the longer you don't have hormones, right? So they're being dismissed for two reasons. The first reason is we don't think they're suffering because we're not listening to them. And number two is the timing hypothesis. So the timing hypothesis says hormones work best by preventing disease. So they work best on healthy tissue, healthy cells, right? So go back, what do hormones do? They help cells stay healthy. Okay. Well, then it makes sense that in order to make healthy cells stay healthy, you got to start the hormones when the cells are healthy, right? And that's the basis of the timing hypothesis. And that's where people take the best time to start is within 10 years of menopause, right? That's what the Menopause Society guidelines say, 2022. They're free. Go read them. Because people will take that and they'll say that means you can't start after 10 years. No, that's not what the guidelines say. The guidelines say benefit outweighs risk, which is actually a very powerful statement in medicine. It's very rare we say benefit outweighs risk in most things. Benefit outweighs risk within 10 years. Start hormones on healthy cells. People interpret that to say the 74-year-olds can't have it. That's not true. That's not true. That's not what the guidelines say. The guidelines say at an older age, it's a risk benefit discussion. What are you trying to treat? And likely we will not give them the preventative benefits. So if we agree that starting hormones early decreases the risk of heart disease and Alzheimer's, which I think the experts are getting more and more comfortable agreeing on that, but you got to start it young. We probably won't prevent things in 74-year-olds. That doesn't mean we're not going to alleviate suffering when started in 74-year-olds, right? Like, these women who are like, I didn't think I had any menopause symptoms. Turns out, though, like, now I'm sleeping. I've been sleeping in 20 years, right? So I'd say about a third of my practice is women in their 70s and older at this point. I'm a third perimenopause, a third normal Barbie, which is the 51-year-olds with hot flashes, and then a third boomers. And if you really look at the data on risk in older people, that risk was with oral synthetics, right? So oral synthetics, that's the Prem Pro of the WHI, does have an increased risk of blood clot and gallbladder disease. Both of those things are removed with transdermal estradiol. The other thing is when people say they can't have hormones. Hormones is a very big tent, right? Big tent. Vaginal estrogen, everybody can have that. There's no age limit for testosterone. There's no age limit for oral micronized progesterone. So when people say older people can't have hormones, what they are saying is oral synthetics that have the risk in older people, but they don't know they're saying that, right? They're basically saying you can't have anything, but I'm like, no, you can. And I break this down for people who are interested. If you go on my website, kellycaspersonmd.com, under courses, I have a specific 1-hour course on the data on taking hormones as an older person. And really, I break it down into 3 things. What are we afraid of? What are we afraid of in starting hormones in older people? Dementia, cardiovascular disease, and stroke, most likely because of clot risk, right? And I break down with transdermal estradiol especially the 0.025 patch. Man, the 0.025 patch is like one of the safest medications known to man at this point. It's like those 3 things go away with transdermal estradiol. So it's really education, right? Why are we afraid? Why do we say they can't? What medication are we talking about? You break that all down and then you're like, oh, it's really not that risky to start a 74-year-old on a low dose transdermal estradiol patch, let alone vaginal estrogen, right? Where there is no age limit. So that's my very long answer to why the boomers should be pissed and what I'm trying to do about it.
And Kelly, can I ask? I know it's obviously very nuanced and obviously we both approach things very individually for each patient, but would you tend to go down the route of checking, cardiovascular testing to make sure the person doesn't have pre-existing heart disease or anything like that before starting hormones?
Let's remember, pre-existing heart disease is not a contraindication to starting hormone therapy, right? People want to use it as one, but it is not a contraindication to starting hormone therapy. And there's multiple papers we can go into, including the HERS trial, which looked at oral synthetics post-heart attack, right? Where they did no worse than placebo. Right. So, and I talk about that in my course if people are interested just to get into it of like why I say that. But heart disease is not a contraindication. Now, somebody comes in and they're 74 and they're interested in hormones, and you're saying, what are you interested in them for? And blah, blah, blah. Like cardiovascular evaluation should be part of every single visit. It's the number one killer of women. Right. So it's like to not use that as an opportunity to be like, how's your blood pressure? How much are you exercising? Oh my God. Do you smoke? Do you drink? Blah, 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 blah. So it's like, of course we should evaluate it, but that's a no brainer. Heart disease is the number one killer of women. It should always be evaluated.
Kelly, many women still seem to think that menopause is just about periods ending and maybe some hot flashes. And if only they can just get through it, then, they can maybe do without taking hormones. And that is still a really big conversation point that women seem to, I don't know, nearly feel like it's a badge of honor to not take hormones and maybe some type of failure on their part if they do end up having to take hormones. How do you think we try and change that narrative?
Education. This is what I know, people are insanely curious about their bodies, right? Like we tell people puberty is a thing, we tell people pregnancy is a thing. And even though puberty and pregnancy are natural, we don't tell you to suffer through them. Like there's significant suffering that happens with puberty and pregnancy. We are here to help alleviate that. Not because you're weak, but because we want to alleviate suffering. That's why physicians kind of got started, right? We want to alleviate suffering. So falling and breaking your femur, that's natural. Do we tell people to suffer through it because it's natural? Right? It falls apart. This whole like, don't treat it because it's natural. Like babies getting stuck in the birth canal is natural. Should we not treat that? Right? It falls apart so quickly that all you have to do is talk about it to be like, yeah, outliving your ovaries, pretty natural. Not common until now, but natural, right? And people forget that 200 years ago, average life expectancy was 47. Do some research. Living to 84 is a gift. But if you choose to live 40 years past hormone production, your body's cells aren't going to be as healthy as when they had hormones. So we will never get to maybe we will, but I don't know if it's going to be in my lifetime, get to the everybody should be on hormones. Because you're like, should I? Should I? And I'm like, you're never going to get a government panel saying everybody should take hormones, but you should have the discussion about it.
This episode is brought to you by my 16-week Rediscover You program, designed specifically for women navigating the challenges of perimenopause and menopause. If you're dealing with disrupted sleep, mood changes, or unexplained weight gain, this evidence-based program combines medical guidance, practical tools, and a supportive community to help you take control of your health. Women have reported significant improvements in symptom management of sleep quality and overall well-being. As an All About You listener, when you mention the podcast, you'll gain priority access for our next intake. Click the link in the show notes to learn more and join. I'd love to help you rediscover the vibrant, confident version of yourself. What are the biggest misconceptions that you're still hearing from patients and clinicians alike, even today?
That hormones cause cancer. which is actually, like, super silly when you think about it, because there's 2, let's talk about 2. There's 2 cancer-causing agents on every street corner that's legal in, like, most countries and makes the government a ton of money: cigarettes and alcohol. We know they cause cancer, right? That's not an argument. And we're like, "Well, you're a grown-ass adult, and you get to make that decision." Right? Like, isn't that crazy?
I know it is interesting how I think culturally everyone definitely agrees that smoking and cancer are related, but people seem to really struggle with the alcohol one because it's like, well, why haven't they banned it then? And it's like, well, that's a very long answer.
There's many, many financial incentives in keeping the society drinking, right? Like restaurants, government taxes, blah, 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 blah. But, governments are coming out and saying, Ireland did, Canada did. Canada said there's no, and Canada, that's got a big drinking culture. Um, so governments are starting to wake up, but they also make a lot of money off of it. So you don't want to bite the hand that feeds you.
Yeah. So, I mean, I'm definitely still finding patients. I even had a patient last week who came in very annoyingly to tell me that the dentist had told them that it was really dangerous that I had put this patient on hormones and didn't they know that these hormones caused cancer. And I was like, thankfully, this patient was super sensible and she just said, oh, I just totally ignored the dentist for saying that. But it's definitely still a massive issue. We seem to feel like the WHI and the hangover of this cancer reputation, like it feels almost unshakable. It's like inbred into doctors and dentists and health clinicians. And I've had patients tell me before they've even been for like an ultrasound scan, and the ultrasonographers also told them that they shouldn't be on hormones or that it's really dangerous or that I have the patient maybe on systemic hormones and vaginal hormones. And again, they're told that that's too much. It's really, really hard to know how we're going to get this whole generation of clinicians to kind of get with the program and get themselves up to date because it can feel a little bit disheartening at times.
Yeah, I mean, it's really changing cultural zeitgeist, and that's for anybody to think that should be easy, like, don't fool yourself. Changing cultural zeitgeist, it's like it's in the ether at this point, Like, I had a woman say, like, she went to go get a mammogram, and the mammogram tech's like, "Oh my god, I can't believe you're on estrogen. It's gonna cause cancer." It's like, do we do that? Do we go to a restaurant and, like, watch somebody drink a beer and be like, "What the fuck are you doing? That causes erectile dysfunction." Right? Like, but it does, let alone colon cancer and, like, all the other things that alcohol's related to. Like, "Oh my god, that causes anal cancer. What are you doing?" Like, we don't do that. So it's this very weird thing that we think it's reasonable to tell people that something your body naturally makes is trying to kill you.
Yeah, and I think the other one that I think is quite interesting is that I had a patient recently whose sister had been diagnosed with breast cancer within 8 months of starting hormones, and the treating clinician told her that, it was probably taking the hormones that had caused her breast cancer, which, I think we would all agree that is absolutely ridiculous. There's no way that in
I
eight
mean,
months.
yeah, that's the problem with hormones is correlation doesn't equal causation, but brains don't know that. And the other thing is, that look at the data when on that horrible Tuesday that you get diagnosed with breast cancer, that awful, awful day, that breast cancer has been there for at least 5 years, right? Like people don't know that. They're like, it happened today. So what's going on today that caused that? And so that's, again, lack of education. The more you know, the more you realize all of these statements are completely ridiculous, but you can't pass that on without educating people.
And as a clinician who's obviously worked a lot with men in the earlier part of your career as a urologist, how do you think that, we position things differently between men and women? Because I don't really see men being told that, that their prostate cancer has been caused by their testosterone in some shape or form. And yet it just seems like there's a layer of blame put onto women that somehow their body has caused it themselves.
For a long time, and this should give hope, right? Is like for the longest time we thought testosterone caused prostate cancer. It doesn't. And but we're getting to know that now. So like the cultural zeitgeist of what a man's hormones naturally make is not trying to kill them. Right? So we've seen it move very fast in men. So that's what is what gives me hope of like, yeah, we'll get there with estrogen. We're just moving slower. But we don't call prostate cancer testosterone positive prostate cancer, which we could. There's testosterone receptors on prostate cancer cells, right? But we choose to do that with estrogen and breast cancer. We call it estrogen positive breast cancer. That doesn't mean estrogen caused breast cancer. It means the cancer cells have estrogen receptors on them, just like every other cell in your body has estrogen receptors on them. I never want to say this is good news, but actually, the people who with estrogen positive breast cancer, they tend to do better because they have less differentiated cancer cells because they still kind of look like other cells, right? Again, this is complex. You can't learn this in 15 minutes at a doctor's visit. But people will say, you have estrogen positive breast cancer. People will assume that means estrogen caused it. No, it just means it looks like other cells, that every cell in your body has estrogen receptors on it. But it's that wording, right? Like I could call every prostate cancer, except for the really ugly stuff that's so differentiated, it doesn't have testosterone receptors, testosterone positive prostate cancer. But we don't say that. And therefore, men don't think testosterone causes it because testosterone doesn't cause it and estrogen doesn't cause it. So wording matters. If you're going to say that, you have to do the extra step of explaining it. So this is what I always tell people. Food doesn't cause monsters in your house, but monsters eat food. So if you have monsters in your house, you got to get rid of the food because you don't want to feed the monster. But that doesn't mean that food caused monsters.
Yeah. And so what I'm hearing you say is that if we think about then the person who's got estrogen receptor negative breast cancer, it's that their breast cancer cell has become sort of so abnormal and more differentiated from a normal cell that the receptors have fallen off and therefore you can't use estrogen to manipulate it. Is that correct?
Mm-hmm. Yeah, that's a trickier monster, right? Because you got to find something else. You can't just take the food away.
Yeah. Yeah. You have less tools in the truck at this stage to manipulate something like that. And also on that stage, I know there are a lot of patients with breast cancer who and we know that the breast cancer and hormones is very nuanced. It's very individual conversation. We know that they can safely have vaginal hormones to deal with their genitourinary symptoms. But what about the breast cancer patient who absolutely cannot have hormones? They don't want to have them. Their oncologist does not want to have them based on their pathology. What do you recommend for that person who isn't sleeping, who is anxious, who is not feeling great at all, but just doesn't have the opportunity to take hormones? What would you do with that?
Well, first remember, hormones is a very big tent.
Yeah.
So when you say they can't take hormones, are you saying they can't take estradiol? Because usually that's what they mean. Don't forget about progesterone. Don't forget about testosterone. Don't forget about vaginal estrogen, right? So I hate when people say hormones because the tent is too big, right? Like it's a big tent. You got to be very specific with me about what you can and cannot take. So usually people don't know that. I think there's a lot of people who can take hormones who think they can't because it's a big tent. They just think it means one thing. Hormones means a bunch of things. Breast cancer, Duovy, right? Duovy is basodoxifene, and like there's and conjugated equine estrogen. Like they're doing amazing things with DCIS pre-surgery. They're doing studies looking at Duovy. So we're moving the needle on what a hormone is and who can take it. It's very exciting, right? So, but to answer the question, let's say somebody's like, I understand the whole tent, and of course they can probably still be on vaginal estrogen. So get on it; it'll help your pelvis. Exercise, and metabolic health. Get your insulin optimized, get your glucose optimized. Do you need to exercise? Is that diet? Is that a GLP-1? Is that metformin? What is that? Because I think so many people feel left out of the hormone conversation when, remember, most people can take hormones. They just don't think they can. But they feel left out. And I'm like, dude, there's nothing better than exercise. Nothing better than exercise. 27% of Americans get the recommended exercise amount every single week. So I know everybody's like, I feel so left out. I'm like, 70% of you ain't exercising, and exercise is I would say exercise is better than hormones. They're never going to do an exercise versus estrogen patch. But if you throw on an estrogen patch and you're not exercising, like, don't think you're moving the needle as much as you can. So that's what I would say to the people who feel left out is like double down on what you better not be effing drinking. If you can't take hormones and you're drinking alcohol, like, don't tell me you feel left out. You better stop that now. right? So, like, I think people, they get into this like, all is lost. And it's like, "Oh my god, no." But, like, buckle up and do the work. And I'm only being picking on people because it's like the average person drinks and the average person doesn't exercise. So don't be average.
That group of women, so you would say they can definitely go and explore, as we've agreed, definitely vaginal hormones, but they could look at progesterone and they could look at testosterone, and that it might be beneficial for some of those symptoms as well.
Yeah, I mean, again, everybody's individualized, right? Like, podcasts are for entertainment and education purposes only. You gotta go see your doctor, you gotta go consult with them. But there's usually more options than what people think there are. And I think, in America, at least, we don't have great data, but to our knowledge, in the breast cancer survivor community, and again, breast cancer is a big tent. That means many different diseases, actually. DCIS is very different than stage 3, but to the data that we have, about 15% of them are on systemic hormones. What does that tell me? Stop lying and saying you can't have anything when 15% of people are actually on systemic hormones after breast cancer treatment, right? So it's really providing that knowledge of, like, you think it's never, but 15% of you are on systemic hormones. Just tell women that. Tell them the truth. They deserve to know that.
Yeah, absolutely. Absolutely. Kelly, there's another group of women who seem to think that hormones are just a flat yes or no. And I would love just get a really quick answer from you. So women who've got migraines, yes or no?
Not a contraindication.
Agreed. Um, Personal history of clots.
Transdermal estradiol, not a contraindication. Oral progesterone, not a contraindication. Testosterone, not a contraindication. Vaginal estrogen, not a contraindication.
Agreed. Family history of clots. That seems to be another one that comes up a lot. Their great auntie had a clot once.
Go to a hematologist, get a clot workup. Know your actual risk, right? Like, don't assume you have a risk or not know. Like, get it worked up. Family history of anything is not a contraindication to hormone therapy.
Yeah, agreed. Past history of endometriosis.
Not a contraindication to hormone therapy.
And a question that they often ask is, but will it make their symptoms worse or come back?
Very rare. There's actually papers on that, and especially if it's been treated, no. And also would add, testosterone is actually probably the secret on endometriosis that a lot of people aren't being offered. It seems to be very nice in that population.
Okay. So on that note, let's talk a little bit about testosterone. Lots of women are definitely knocking down my door wanting to talk about testosterone. They're seeing people chatting about it on social media.
Did Australia just get Adrofem on the PBS?
I have not heard the result.
It's like literally this week or something.
I keep Googling it and I'm not seeing anything coming up, and there certainly hasn't been an announcement. So we're waiting with bated breath.
Okay. Well, so are we. Text me when you hear anything.
Yeah, I will. So talk to me about testosterone. I'll tell you what my experience with my patients is, that it is, in my mind, a bit of a slow burn hormone. So in comparison, like if you've got really bad hot flashes and I give you some estradiol within a couple of days, you'll love me because I've probably got rid of your hot flashes. But if you're struggling with like low libido and I give you testosterone, I feel personally it takes quite a while to work. Is that what your experience is as well?
Everybody's different. And I mean, it always depends upon, like, what dose they're on, how fast did you get it up, how low was it in the first place, right? So it's definitely individualized. But here's my joke: there's two people, there's two groups of women with testosterone. There's the first group of women who, like, it works very quickly. By like 2 weeks, they're like, "Oh my god, you changed my life. This was the icing on the cake. This was it. Finally, energy's back, sex drive is back, everything's back. I love life. Oh my god, the world's amazing." And then the other group of people hates those people.
That's true.
Because for them, it's like, dude, it might be 4 months till the humans are good looking again,
Yeah.
right? Like, it might be very subtle. And often I'll have women, I'll be like, "Hey, can you tell if I'll do like a 4-week or a 6-week follow-up. Hey, can you tell if the testosterone's changing anything?" And they'll be like, "No, I don't think anything's changing." And you just pause. But I had, like, amazing sex last night, right? So, like, things are changing, but it's not a light switch. But when they think about it, they're like, "But my knees and hips don't hurt anymore. Right? So it's like it's subtle. They'll say they don't it's not a light switch, but something's different. Something's better. So I think that's like the slower, you don't remember how crappy you felt. You're like, I don't know if I'm better or not, but like just redid my deck outside. Right? Like, this is like, I think you have more energy now.
Yeah. They're suddenly meeting their friend for that 6 a.m. walk again. So,
Right. Yeah, yeah, yeah. Yeah, or you have somebody and they're like, I'm not sure if it's better or not, but I did just sign up for a 5K because I feel like it now. And you're like, okay.
yeah.
So yeah, it's like it's a light switch for some people, but the other people it's not. And that's why those people hate the light switch people because they're like, isn't it supposed to be like that for everybody? And you're like, no. Like it's so everybody's so different. Like, did you have any testosterone receptors left or did they all just go to sleep because you haven't had testosterone in a while? It takes a while to get your receptors back. It takes a while to get the cells healthy again, right? Like things take a while. So the guidelines say if after 4 to 6 months, if you're not feeling any better, you can stop it, which I think sounds fair. But just to counter that is like, yeah, but it helps bones and it helps lean body mass. And like, you can't really feel all that stuff. So like, you could just stay on it if you want to. But I talked to a lot of people, like, by month 4, the humans are good looking again. And again, going back to libido is incredibly complex, right? Testosterone will only fix the part of libido that is because of low testosterone. It won't fix all the other parts.
Yeah, absolutely. If you don't like your partner, then that's not going to work out really that
Yeah,
well
if you
for
don't like
you.
your partner, testosterone won't help you.
Can you explain what is actually happening to testosterone? Is it doing the crazy things that estrogen and progesterone are doing in perimenopause, or is it a slow descent, or what do we know what's actually happening?
Yeah, it's more of a slow descent. We don't know why. Aging, right? But, like, testosterone's the highest in our 20s and then slowly goes down. And I think that's actually used against women. How I see it is used against women because people are like, nothing happens with menopause and testosterone. We're like, every expert knows that nothing happens with testosterone and menopause. And what I mean by menopause is 1 year after no natural periods, right? Like, testosterone doesn't fall off a cliff. But often that's used against women, right? Because they're like, "Well, you should only use it post-menopause." Well, that makes no sense because nothing magical happened with testosterone in the day of menopause, right? It's a slow decline since your 20s. So that argument is like, oh, perimenopause could benefit by it because there isn't something that happens at menopause. And I want to make sure I'm being clear. That's used against women to say you shouldn't need testosterone in menopause because nothing magical happened with menopause and testosterone. We're like, yeah, we know. Started going down after our 20s. Did I say that? Did I make that clear? Of like how that fact's being used to kind of, I think, dissuade women from using testosterone.
Yeah, absolutely. And it's definitely something that I think women are starting now to get confused about. So I think the last couple of years they've been hearing about testosterone, and then now they're hearing sort of some confusing information about testosterone. And I suppose, we're left with a group of women who yet again are becoming confused as to what they should be doing. And I think they just need to have a personal conversation with their doctor that they trust and come to the right conclusion for them.
Yeah, well, but you need a doctor who I would say you need a doctor who prescribes testosterone. Right? Like, you need somebody who's trained in it to give you an opinion. 'Cause I'm like, I could give you tons of opinions about things I don't do. Right? But it's like, that's not as good as, getting an opinion from somebody who does it.
Yeah, absolutely. Well, I mean, just like I'm sure, like you, I prescribe testosterone, but I don't prescribe it to everyone because it's not necessarily going to be helpful or appropriate for everyone. And they might decide that they don't want to do it either. A lot of women are really scared that they've already got thinning hair with their um perimenopause and menopause, and they're worried that if they go on testosterone, all their hair is going to fall out. Do we know what the data is on that?
Do all men have no hair?
I was going to say, for someone who's got a really cool mop of hair, answer that question about
Well, I mean,
hair.
that's my first argument because I want people to think, right? Like, does high testosterone mean no hair for everybody? No, because there's tons of men with really high testosterone who have tons of hair, right? So I wanna break that. 'Cause what you're saying is women think high testosterone means no hair. No. Do trans men, are they all bald? No. Okay, so those were female bodies that now are trans men. They're not all bald, right? And what I'm saying is I wanna break apart that myth that high testosterone means no hair, not in everybody. But let's talk about hair. 50% of women have issues with hair thinning in midlife, whether or not they take hormones or not. Again, correlation doesn't equal causation. You start hormones 2 years later, your hair falls out. It's not because you're on the hormones. It's because 50% of women have thinning of hair in midlife. Incredibly common, not talked about. But number 2 is if you look at pellet data. So this is the two things, and I'll try to state it so people can follow. If you look at pellet data, there is some hair loss with pellets, but there's also some hair loss with placebo, and they're equal. I believe that data. I also believe the women who say, I got pellets and my hair fell out. So how do you reconcile that? Hair hates drastic changes, whether that's postpartum, whether that's rapid weight loss, whether that's thyroid issues and change in medications. Hair hates it. The body's going through a shock. The body's like, I don't need to make hair right now because I got some shit going on, right? So if you do rapid hormone changes, it shocks the hair follicle. And that's why I say, people have to earn their high doses of testosterone. Start low, go slow. That's what I always say. Start low, go slow. Because if you have no testosterone and you kick it up really high, hair hates drastic changes, whether that's thyroid, whether that's anything. So I have to explain that all to be like, it's quite possible you experienced some hair loss when you started hormones. Did you go too fast, too high? Well, don't do that. Hair hates that, right? But it is not a one-to-one direct correlation causation that testosterone causes hair loss, and the studies don't support it.
Is there any other things that you are seeing in practice? And I know that, everyone wants these sort of randomized control trials that prove X, Y, and Z. I don't think we're ever probably going to get them. But, in clinical practice, and obviously I know that you work with a big group of colleagues who chat all the time, what are the other benefits that you see testosterone giving women in your practice?
Well, some people say their hair grows. So that's like the counter to the hair loss. It's like some people are like, oh my God, my hair's amazing on testosterone. Some people testosterone helps them sleep. There's like no studies on that. Helps mood, helps depression. Dr. Louise Newsom published an abstract this year showing better ability to get off of SSRIs when starting testosterone compared to estrogen alone. So that's super exciting. More ability to get back in the gym and get exercising, mostly due to decreased musculoskeletal aches and pains. That's another Louise Newsom abstract from this year. So improvement in physical activity, but really where you tie in the libido, because that's where people will be like, it was only studied for libido. First of all, that's not true. It's been studied for many things besides libido. But when people are like, we should only use it for libido. Well, what's libido? Libido is a motivation. It's a drive towards. It's a dopamine pathway, right? It's the brain paying attention and being interested in something external, right? And that is a universal brain thing. When it does that, libido's part of that. So thinking about it in that sense of testosterone's all over the brain. It's not just in this one corner that's like the libido box. That's how I call it. And women will say, I don't just have a libido for sex, I have a libido for life, right? I have a motivation towards something. I have an interest in things. That is a drive or a libido or appetitive, right? Appetite driven. And it really I was a super nerd. I was a neuroscience undergrad, which is why I think I get so interested in explaining this to people, is because to say testosterone is made by the ovaries only for you to have sex is so boiled down and wrong with like how the body functions. It's not how the body functions. The body will make one thing and it'll help lots of things, right? If testosterone was only for libido, why are there receptors in our bones? Right? So I just think education is the way forward on this. Like people are ultimately fascinated about their bodies and how they work, and they should have a right to knowing how their bodies work.
Yeah, I think it's so interesting that you have that undergraduate background. I don't know whether maybe I was daydreaming at medical school, but I genuinely have no recollection of anyone talking about estrogen or testosterone or having anything even to do with the brain in any shape or capacity other than, sort of FSH and LH coming, from the brain and telling the ovary, blah, blah, blah. But yet every day, if I think about the main reasons why women come to see me, like, hot flushes isn't at all the number one thing. It's not being able to sleep. It's feeling really anxious. Like, it's brain symptoms. Like, that's
Yeah.
probably
It's not feeling like myself.
yeah, all the time.
NFLM, which is actually it's more and more published on. 40 to 60% of perimenopausal women don't feel like themselves. And my argument is, as a physician, if there's not something more important to help somebody with than feeling like themselves, like curing cancer is very important. Don't get me wrong. But my God, making Susie feel more like Susie is a really good job. And that's where the hormones come in.
Yeah, 100%. It's just so interesting because I think nearly all of us need to go back and do a little bit more study, or yeah, I think it's just so
No, it's insane.
interesting.
Like, you start researching testosterone and you're like, oh, it helps the myelin sheath, which is the protective coating around the neurons, right? Oh, it helps the glial cells, which are the supporting cells that help keep neurons alive, right? Like, when you actually start understanding what testosterone does in the body, and oh my God, there's probably a role for Parkinson's disease and multiple sclerosis, and we know it helps prevent dementia and depression in men. Like, once you start learning about testosterone, when people say stupid shit about testosterone, you're like, "Oh my god." Right? Like, they just don't know. They don't know.
It's just like, I don't know, sometimes I think in medicine, we just want to distill things down into a little box. And if it doesn't fit in that box, then we don't like it. And I think I had a patient, she said to me the other day, why do you think everyone's talking about menopause all of a sudden? And why did no one talk about it for a long time? And I mean, I've got lots of things that I think about that. I think women in medicine, women of urine, my generation going through their own symptoms suddenly made people talk. I think social media, like, I think there's all these reasons. But I do think medicine is really bad about one thing, if we don't have a solution for something, then on the whole, we don't want to talk about it.
Well, yeah, well, even worse, it doesn't exist.
Yeah.
And maybe that's a fun Viagra story, because before Viagra came out, erectile dysfunction was in a man's head.
Oh, I don't.
You went to therapy. You went to therapy for your erectile dysfunction before Viagra got invented, because medicine didn't have a solution for it.
Yeah, it's so interesting. And it's, I think as you get just a little bit older, you begin to question that narrative generally. But I feel like, lots of people going, oh, why is everyone talking about menopause all the time? And it's like, well, as I said, all the reasons I've already said and many more. But I just think that we're finally able to, because there's now feels like there's a solution again, so we can start talking about it again.
I think you're right. I think you're right on all of those. And for 20 years, right, hormones weren't a solution because of the WHI, which is super funny because the WHI actually told us a lot of useful information about hormones. It was just the fear part that, like, killed the whole thing for us.
Yeah, I know. It's maybe like we've thrown the baby out with the bathwater a bit, because maybe there's some really good data and now everybody hates the WHI study.
Yeah. Yeah, it's like we actually should redirect the hate. We should redirect it towards the media,
Yeah,
right?
absolutely.
And not that, like, 'cause the WHI, it said what it said. It was the misinterpretation of it that caused the problems. Like, and that's what's so funny is, like, you guys, the WHI study from 2002 is free online right now. Google it. It's JAMA. It's a free article online. Are you kidding me? You mean ever since the internet came out, you could read this damn thing for free online today? Yes. Guess how many people actually chose to do that, right? It's a lot easier just to believe somebody than to check it for yourself.
Here are my 3 takeaways from today's conversation with Dr. Kelly. An entire generation of women was let down, but it's not too late. So many women in their 50s, 60s, and 70s were denied hormone therapy because of outdated interpretations of old research. Understanding your options now is an act of empowerment, not regret. Evidence matters more than fear. Modern data tells us a very different story about the safety and benefits of hormone therapy, and women deserve care based on current science, not decades-old headlines. Testosterone is much more than libido. For many women, it supports motivation, vitality, cognition, and a sense of self. It's a legitimate part of midlife health when used with the right guidance. Dr. Kelly, thank you for bringing such clarity, courage, and evidence to a conversation that has been clouded in confusion for far too long. The Menopause Moment is an extraordinary resource, and I know so many women listening will feel seen, validated, and better equipped to advocate for themselves. You'll find links to Kelly's book and her podcast, You Are Not Broken, in the show notes. If this resonated, please follow the show and share it with a friend. And remember, this information is general in nature, not intended to replace personalized medical advice. Always speak to your healthcare provider for guidance about your own situation. I'm Dr. Shauna Watts, and I'll see you next time on All About You.